We are proud to announce that today's webinar is in collaboration with the National Registry of EMTs. Today's webinar is titled Clinical Judgment and National Registry ALS Examinations, presented by Dr. Paul Rosenberger, Examinations Content Manager of the National Registry of EMTs. I'm going to pass it over now to the NAEMT team. Thank you so much for being here today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you so much, Rio. Hi, everyone. My name is Emily Kirchner. I am the event coordinator here at the National Registry. I first want to thank you all for being here. And secondly, I want to extend a sincere thank you to the National Association of EMS Educators for hosting us. A couple of points of housekeeping before we get into things. Today's webinar will run for a maximum of 1 hour. And as Rio said, we absolutely welcome questions, so please submit them throughout via the Q&A function. And we appreciate your partnership. And with that, I will turn things over to Paul Rosenberger.
All right. Thank you, Emily. Thank you, Rio. So here's what we're going to talk about today. This is our roadmap for the next hour. First, we want to contrast, what does it look like to be competent, not yet competent, and marginally competent. So we'll have a discussion on that. We will then talk about the 4 common domains within EMS competency or knowledge. And then we'll wrap this up with discussing methods and concepts related to the assessment of clinical judgment competency. And so this is the path we're going to take. So the first part of the lesson is this question is, what is competency? And so I'm going to ask you to do this. This works certainly better when you're in a classroom with people, but we can do this through Zoom. I want you to close your eyes and think about 3 providers or 3 students that you commonly work with. And the student with the gold star is that student that you would think of as being competent. And so close your eyes, think about that person. Bring somebody to mind that you would think is that person that's super competent. And I don't think that should be an instructor or the program director. I think that should be one of your students. Who is that student that sits in your classroom day in and day out that you think of as super competent, that you have a lot of confidence in, and you know that when they get out in the field, they'll do a super great job. So at this point, I hope you have a name of that person. Now I want you to go to the other side of the spectrum and think of that student that is not quite there. They're working hard. They're trying to learn, or maybe they're not super motivated. But who is that student that you would say this person is not quite there yet? And so we know that we have a good bit of work to do with this particular student. So think about that person. So put a name to that side of the equation. So we've got the gold star, and then we've got the person that's not so much the gold star. So we've got 2 names now. And so now let's think about a 3rd student. And that is the student that is marginally or minimally competent. So they're competent. They could go into the field, but they're not quite the gold star. And so they've got a lot to learn, but if they went out on an EMS call today, they probably could get the job done. And so with that said, we should have the competent student. We have the student who's not yet competent, and we have that student that is marginally competent. So keep those names in mind. All right, so let's think about that person that you said was competent. And so when we talk about what is competency, these are some of the things that will help us describe what that candidate looks like. And so here you go. If you run through this list, a person who is a strong clinician can and are able to consistently recall and correctly recall foundational knowledge and practice. And they can operationalize that information into action so they can actually take care of a patient. They understand and incorporate training into practice. They're able to serve as a resource for others. They can adapt and adjust to changing situations. And when they need help, they know when to seek that help And, it's not often, but we all need some help. We don't know everything. And so they know who to seek out for that information. And when they learn that information, they're then able to apply that to future situations. These clinicians also tend to be self-starters. They're confident. They can manage tasks without anyone telling them what to do. And they can take what they learn and apply it to a variety of situations and settings. And they tend to be leaders. And they also tend to be detail-oriented. So I'll stop and ask you, that person that you thought was competent, or that person that you really thought was going to do super well in the field, does this describe that person? And you don't have to answer out loud, but I hope you have a yes in mind for that. So we'll go to the other side of the equation here, and let's talk about that person that you didn't think was quite ready yet. And so these may be some descriptors of them. These clinicians have failed to demonstrate competency and or proficiency as a provider. They're probably unable to recall basic information or definitions. They fail to understand definitions and apply basic principles. They're unable to apply information. They don't see the interconnectedness of issues. They tend to have a false sense of knowledge, meaning that they don't necessarily know what they don't even know. They don't seek help, and they tend to resist training or remediation. And so this person clearly is not competent. And I don't know who that person was that you thought of, but I wonder if this describes that particular individual. So we have the competent and the not competent. The marginally competent is the one that's a little bit more challenging to define. And so in the next few slides, we'll kind of talk about how do we determine this. But this marginally competent person, and some of this definitely is worth debate, but this is a nice starting point here. These folks are unable to accurately impart or communicate information to others due to having minimal knowledge of their practice. So they understand their practice, but they're not quite sharp enough to share that with others. They know just barely enough and may require some mentoring. So think about the day that we all walked out of the paramedic classroom and we got on the back of a truck. I would dare say that I was barely competent at that particular day. And I've grown a lot since then, but I knew enough to get the job done. They may not always understand the why. They may need to rely on others for information. They lack a full understanding of the important constructs underlying their credential. They often can't think outside the box to understand their own actions and decisions. And they fail to have the necessary breadth and depth of the field to fully understand implications of their actions. They fail to understand how their actions and decisions may impact the quality of outcomes. They're unable to consistently translate information into practice. They tend not to be self-starters or leaders. They need reassurance. And they lack the depth and breadth. And as a result, they tend to second guess themselves. And so we could have a lot of discussion as to whether this is competency or not. But this is definitely a starting point to say, is this person minimally or marginally competent to go out and practice as a EMS provider, whether that's an EMT, EMR, AMT, or paramedic. But the way we would determine that is involve a lot of SMEs and use a lot of metrics that are available to us to actually decide who's competent, who's not. And so when you look at this, this slide is just illustrating that, to determine who's competent and not yet competent, it's truly a spectrum. And so I think that person that you said was the gold star is clearly on the left side of the screen. The person that is not necessarily competent, they're not the gold star, is clearly on the right. And then we have to decide everybody else who's in the middle, are they competent or not? And as we all know that we send students out of our classrooms and we want them to be entry level ready. And so to me, that word's synonymous with minimally or marginally competent. Over their career, they move more towards that gold star if they're a really good provider. And so how do we determine that bar, that minimally marginally competent? We use SMEs. and we use item metrics, and we have debate, and we reach consensus as to what that minimal competency is. So there's one SME there. We involve a second SME, a third SME, a fourth SME, a fifth SME, and you get the point. We don't do this with just 5 people. We do this with as many SMEs as we possibly can involve with this. But that collection of information and that debate and that consensus and the use of metrics helps us define what minimally and marginally competent is. And so again, it takes a lot of things to say, yep, this person's got it, or no, this person doesn't have it quite yet. So with that said, I'm going to transition, and we're going to talk about these domains within EMS competency. And so kind of give you a roadmap. We have 4 domains of knowledge that we teach and test for entry-level providers in EMS. And that first one is that of declarative knowledge or informational knowledge or foundational knowledge. And in the next slide, I'm going to elaborate on what that means in just a second here. That second domain is procedural or mental knowledge. And then the third is the psychomotor domain. And then lastly, this new concept where we're going to spend a lot of time on is clinical judgment. So the first question is okay, what's this declarative domain? And when you break it down, it's these things that are listed down below. It's vocabulary. So can that provider speak the language of EMS? So we want them to know terms like bradycardia and tachycardia and tachypnea, bradypnea, all those terms. That's definitely declarative knowledge. We want them to know facts. So for instance, the heart rate of an adult person is typically 60 to 100 beats a minute. We want them to know normal glucose values and more facts like that. We also want them to know time sequences. So perhaps a time sequence would be the modern EMS started probably somewhere in the mid-1960s and has evolved to where it is today. We also want to measure generalizations. I would illustrate these as take-home points. So when we're doing cardiac arrest or taking care of a patient in cardiac arrest, we know that minimally interrupted CPR and early defibrillations, when it's indicated, produce better outcomes than when we interrupt CPR or we don't defibrillate timely. And so those are some of the generalizations that we teach, or the take-home points. Finally, we have these things called principles, and principles are a combination of generalizations and how they are interrelated to each other and how they help us take care of a patient as best as we can. So this declarative information is really the what of our industry, of what we do. We then move on. The second domain is that of procedural or mental. And when we think about this domain, we're talking about things like single rules. And so a single rule, an example of that would be when we're doing CPR, we want to compress 100 to 120 times per minute. We want to press hard, and we want to press at least 2 inches. That would be an example of a single rule. An algorithm, we're all familiar with these. You know, think about in your mind here, the American Heart Association, ACLS, you know, they have an arm for those patients who are in VTAC and VFib. And they also have an arm on that algorithm for those patients who are in PDA or systole. And so we use these all the time. We memorize these, and we take care of patients who are in cardiac arrest. A tactic is much like an algorithm. The difference being is that there's not necessarily a sequential order that things have to occur. And so the example I could use there is, you know, when we come onto a call, we teach our students to recite BSI, scene safety, number of patients, resources, nature of illness, mechanism of injury. Do we need to consider the C-spine? Those things are written on the skill sheets in a linear fashion, but they don't necessarily have to occur in any particular order there. So a tactic is things that we need to get done, but the sequential piece of it isn't as important as it is in an algorithm. And then finally, we teach our students macro procedures, which is really a combination of single rules, algorithms, tactics, and other macro procedures, where we produce a diversity of products or outcomes. And the example I would give you here is we teach our patients or our providers to take care of patients, from start to finish. And the other macro procedure might actually be running the EMS call. So when we get on scene, we use a macro procedure to take care of the scene, but we also use one to take care of the patient. And those are used in combination to have a good outcome for our patients. So that is the how to do things in our industry. The third is that of psychomotor. And as you well know, when we look at this domain, we look at it in a simple fashion and more complex. The simple fashion is where we test a skill in isolation. And so the picture on the bottom left is that of the interosseous station. And so we ask students to come into our laboratories and demonstrate their competency in starting an IO. And so they run through those steps and they perform the skill. And if they do it well, then we say we're competent or they're competent. If they don't, we say they're not. And then on the more complex side is things like actually running a call. So maybe this is simulation within a scenario where they take care of a patient from the dispatch phase all the way to the time that they would transport a patient to the hospital. And this, of course, would include all of those isolated skills. Like in this case, they've got a patient attached to a heart monitor. There's a nasal cannula going. There's some lifting and moving and loading of this patient. And so that would be more of a complex assessment of that psychomotor component. So they test motor skill here. The fourth is this clinical judgment. And I'm going to unpack this slide in a few minutes here. But clinical judgment really is two things. It is clinical reasoning, and it's also clinical decision-making. Those two packaged together or sandwiched together is actually what clinical judgment is. And so when we get on a call, we have to reason our way through that call, and we have to make a series of decisions, and those are reflected as judgments that we make. Is this patient having shortness of breath because of an anaphylactic reaction? Is it because of COPD? Is it because of asthma? Is it a toxic inhalation? But through the assessment, the reasoning and the decision-making, we then come to a judgment and take care of our patient in the lab, in the clinical setting, or even in the field setting. So how do we assess all of this? There's lots of ways. For that first domain, that cognitive domain, we typically use items such as multiple choice, multiple response. And also, we are rolling out these technology enhanced items, which is way beyond the scope of the lecture today, but lots of ways to measure that cognitive domain. The really nice thing about cognitive items, is they allow us to measure breath. So we can ask questions about patients who are having strokes, heart attacks, sickle cell disease, trauma, whatever. We can measure lots of areas of knowledge. And really what we reach out and measure is breath. Another item that we can use are multiple response items. And so in this case here, you ask the question in the STEM, you ask the students to do something, in this case, answer the 3 correct answer options. And we give them a list of 6 and say, which of these 3 things are associated with asthma? Which of the 3 things are not associated with asthma? And then they kind of go through that, they compare, contrast, and decide, hey, these are asthma and these are not. Again, this allows us to measure that breadth. When we use multiple choice and multiple response items, we tend to use tools like this. I think everybody's familiar with Bloom's. And we use these tools to help us write our items at a decent level for measuring competency. And so if you've ever looked at this Bloom's pyramid before, the remember and understand is typically considered to be a low order thinking item, whereas the areas of apply, analyze, and evaluate tend to be of high order thinking. And so the remember and understand is super important because it builds and allows us to apply, analyze, and evaluate. But when we build examinations, we want to measure all of these concepts. And probably at the beginning of a course, we want them to remember and understand things because we want them to understand the language of the profession. But as they move through the course and get towards their completion, We want them to be able to apply, analyze, and evaluate that information. And of course, multiple choice and multiple response items allow us to measure these concepts. This is Bloom's. There are others. There's Marzano's as well, if you haven't looked at that one. But it has a structure much like Bloom's. And their area, apply, analyze, and evaluate, tends to be more of knowledge utilization as opposed to remember and understand. When we assess the psychomotor components, we then, again, I mentioned earlier, we have those isolated skills. And so the traditional way of doing this in the past has been pulling out a skill sheet of some sort and having the student demonstrate that they can start an interosseous line, following this sheet and doing everything that's on the sheet and getting scored at an area of about 70 to 75% and not hit anything like the critical fail criteria. And that's typically how we've done skills in the past. And so we bring them in, we line up all our mannequins and a bunch of tables and a lot of testers, and we run them through the process. It's a good way to measure these isolated skills, but it doesn't necessarily tell us whether they can put this all together and run a call on a true EMS event. And the way we do that is ask them to take care of a scenario. And so here you've got a patient who's having, it looks like some type of cardiac emergency. There's an IV set up. There's an IV monitor, or on line 2, there's an EKG monitor. And they're taking care of this patient, and they're involving a whole lot of those isolated or discrete skills. And then we're able to score that and say, yep, can they put it all together or not? Before we move on, the psychomotor examination for the AEMT and the paramedic is going away soon. And so these are some of the timelines for that. And so the truth of it is that the psychomotor retirement will occur on July 1st of 2024. And the sunset will end June 30th of 2025. And so what that means is the only people that will be doing psychomotor testing during this period after July 1, 2024 are those candidates who have passed a cognitive examination before the end of the sunset. And so I'm trying to describe this as best as I can, but the students who have a cognitive examination at the AEMT or paramedic level prior to July 1 will be able to continue on and do a psychomotor examination for up to 1 year after the sunset begins, which is July 1st of 2024. And then at June 30th of 2025, there'll no longer be any type of psychomotor testing. And so those are really big dates. Get ready and make sure your candidates are ready for this. That fourth area is measuring that clinical judgment. And the way we measure that is through the use of performance examinations. And really, performance examination is an examination that asks a candidate to demonstrate their knowledge and skill through a structured process. And that structured process is it has a purpose. And at Registry, our purpose is to credential folks, to say, to certify folks so that we say, yes, this person is competent or not. But at the program level, you're trying to measure that student to see if they're competent and ready to go on to that next stage of certification. So that's the purpose. The prompts that are being used are scenarios. I'll show you one of those here in just a second. But these scenarios have a phase for en route. They have a phase for on scene, and they also have a phase for post scene. They then also have response demands, and those are truly just the questions. And so we ask a series of questions about the en route phase, the scene phase, and the post scene phase, and say, can you demonstrate, that you have the knowledge, the skill, and ability to manage that patient en route, on scene, and post scene. Those then are graded or rated. And so we are also looking at how do those items perform, but we're also seeing how the candidates did with those particular items. And with that, it allows us to determine, did the item perform and did the candidate perform? Performance examinations have some qualities. They tend to be authentic. What that simply means is that they are a true assessment of the knowledge, the skills, and abilities that are needed within the profession of EMS. Being that they're being introduced to the candidates, they, as a scenario, en route, on scene, post scene, they tend to have high fidelity. So what they're answering or responding to is much like what they will do when they get into the field. They tend to be contextual, and so that means that it's going to be, the items can be written in a fashion that's similar to the way, or in the context of the way that they will actually go out to practice. The cognitive complexity has everything to do with what we just showed you with Bloom's, the analyze, the evaluate, and the apply. These tend to be more in-depth, not necessarily a lot of breadth, because the in-depth is we look at a candidate's ability to take care of a call and a patient from en route to the time they actually hand the patient off at the hospital. And so we have a nice look at, can they manage a patient who has a diabetic emergency or a stroke emergency or a cardiac emergency or a trauma emergency? And can they take care of that patient from start to finish? The scenarios that are being written tend to be isolated to only one emergency. So this is not a call where you start out with agitated delirium. It then goes to cardiac arrest and then goes to anaphylaxis. You know, that would never happen. It would be just a patient that has one emergency start to finish. And we just want to measure, can they manage that particular incident and patient? They also tend to be credible. This is where we talk about reliability and validity, and the use of a lot of SMEs to help make sure that the information is clinically accurate and up to date and just plain credible. So that when they get to the test center, this is going to be something very similar to what they would do when they actually become an AMT or paramedic in the field. And so here is really where the meat of the lesson is today. So here is the clinical judgment theoretical framework. Emily's going to drop the link into the chat here so that if you want to go read this article, you can. It's actually a very short read, but it does describe this graphic. And so there's a lot of folks that put a lot of good work into this, and involved a lot of SMEs across the industry and across the nation. And they try to define what is clinical judgment. As I mentioned earlier, it's the reasoning and the decision making, but it is more specific to, in our case, in EMS, how do you take care of a patient on scene, en route, and post scene? And so it considers things like leadership and communication. And if you look at the three circles here, you'll notice that there are 6 steps in those circles. And the first one is recognizes cues. They then analyze cues. They make a hypothesis, or what do they think they're dealing with here. They generate some solutions about how they're going to manage that situation. They select an action, and then they evaluate all of that to make sure that they're on path for managing an incident and taking care of a patient here. And if you look at those 3 circles, it's the same 6 steps within those circles. And so when you think about when we take care of an incident or a patient, it's exactly what we do. We get introduced to something, we start recognizing things, we start sorting through those things to see what's important, what's not important. We start coming up with like a hypothesis or a general impression, or you know, what are we dealing with here? We try and figure out what our solutions are for that. We pick the very best action, and after we do that action, then we want to reevaluate it to make sure that that action is doing good things for our scene and for our patient. And so again, what you see there is a series of steps en route, on scene, and post scene. And what that allows us to do at registry is create an item for each of those steps. And so we're going to look at some of those here in just a second. But the truth is we could generate up to 18 items for each scenario, but we probably won't. It'll probably be somewhere between 9 and 10 items for the entire scenario. In this piloting phase, there are, the AMTs are seeing 18 items, but eventually it won't be that many. And the paramedics that are seeing these as pilot items are seeing about 9 to 10 items per scenario. And so when you look at that very bottom bar, you see there's cues from the patient. So these are things that we actually see or assess from our patients. Of course, being that we're in EMS, we are out in the environment, so there are environmental cues. So I am in Dallas, Texas. It's about 26 degrees today and snowy. That might be relevant for a response. That might be relevant for a patient, and that might even be relevant post-scene. And so those are all things that we have to consider and factor into these scenarios. And then, of course, the provider factors are things like, what is the level of the provider? Who's on scene with this? Is PD there? Is the fire department there? Or something else? Are we in a dental office or something like that? But those would be just lots of cues that we could enrich these scenarios with to measure clinical judgment. And so here is this journal article I just mentioned ago. This is called a proposed theoretical framework for clinical judgment in EMS. It is specific to EMS, and it is just that it is a theoretical framework that has been proposed as to what clinical judgment looks like in EMS. Prior to this article, if you were teaching clinical judgment in EMS, we'd probably be talking about things like decision-making and problem solving and critical thinking. And that's great, but this is a little bit more defined and a little bit more precise as to what clinical judgment is. So if you go to this article, you'll see that the graphic that I just mentioned there, and I'll describe that graphic in much more detail. When you think about this graphic, it's really not a tool for our students. It's really a tool for us as educators. And so it's a tool that when we build our debriefings, our simulation, we really should be asking our students, well, what did you recognize? What did you analyze? What did you think you were dealing with here? What were some solutions that you could have? What action did you take? Why did you take that action? And how did you evaluate that action? So this is really a tool for us. It's a high-level theoretical cognitive construct for EMS clinical judgment. And it truly is a tool for program directors, faculty, and medical directors. And so again, it's a tool for us to build foundation from. And so people ask me often, how do I teach this in the EMS classroom? And I would tell you, every time you do a simulation or a debrief of some sort, I would follow that format of the table. Again, I would ask them to recognize those cues that we gave them, analyze them to see what's important, what's not. What did you think you were dealing with? What solutions could be possible for this scene or this patient? What actions did you take? Why did you take those actions? And then lastly, how did you know those actions were working or not working for you or for the patient? And so what you see here on this slide is the template. And the template is information that we would enrich a scenario with. And so at the very top here, you have the box that says dispatch information. And so in the scenarios that your students will see at the National Registry examination, they will have information related to the time of the call, the response time, so how long does it take them to get on scene. We'll tell them how their crew is configured, who else is responding with them. We'll tell them something about the scene setting. So, are they going to a residence, to a highway, a high-rise building, or water, or whatever. We'll tell them about the environmental setting. Is it fall? Is it winter? What's the temperature outside? Those kinds of things. And we'll tell them about the facilities that are around them. And so they will get those 6 pieces of information. We will then ask them a series of questions. And at the very bottom section here, recognize, analyze, hypothesis, solutions, takes actions, and evaluate. Again, we could generate up to 6 items from that. And in the midsection are things that could enrich that phase of the EMS call. So, I'll pick out time pressures here. Perhaps an illustration of that is when we get dispatched to a cardiac arrest, we know that we want to arrive on scene quickly. We want to start CPR quickly, and we want to defibrillate quickly when that's indicated. For a patient who's in anaphylaxis, we want to administer epinephrine early on. And so those are examples of time pressure cues that could be enriched into this scenario that could generate some items for our candidates. And if you go through this, there's just a whole bunch of other ideas as to what you might want to enrich these scenarios with. And so you don't have to be super creative because everybody's run calls, and that these enrichment factors can help us generate items and make those students think about what they're going to see. So here is a illustration. This is what we're going to look at here in just a second, but this is what a scenario might look like for an AMT when they get to Pearson VUE. And so it reads, the AMT is dispatched to a dentist's office. So we're telling where they're going for a 32-year-old patient. So a little bit of information about the patient and their complaint. They're weak, dizzy, and slightly agitated. The time of the call is 10:15 in the morning, and the response time is about 9 minutes. So I don't think there's anything crazy or abnormal about that. I think that's probably a call that we could run on any given day. So then we go down and we tell them, okay, here's your configuration. So the EMT partnered with an EMT, and they have a BLS fire department engine crew dispatched with the ambulance. So we now have EMS and fire responding to this incident. The patient's located inside the office, and it's a rainy day. It's a cool spring morning. Temperature is about 42 degrees. Note that we give that in Fahrenheit and Celsius. And we tell them about the hospitals that are around them. So a small hospital is located at 12 minutes away, and there's a stroke facility at least 30 minutes away. And so that's the information that they would see. And now we're going to generate questions again about recognizing cues, analyzing cues, generating a hypothesis. What are some solutions that they might have? What actions might they take? And then reevaluate that. We would then move them to the seeing phase after they answer those questions. Again, we have that same circle with the same 6 steps. We would then tell them information about the scene setting. So we might give them a little bit more information. I'll show you on the next slide here. We tell them about the chief complaint, the history of the present illness, and the past medical history of the patient. We then give them assessment information and vital signs. And if there's a graphic that's related, we will include that. This is an AMT scenario, but if this was a paramedic scenario, we might include a forward lead ECG so that they can determine what the rhythm is. But at the AMT level, they're only requested to acquire and transmit EKG, so they would not have to interpret that at the AMT level. But again, if you look down at the bottom, there are the 6 steps: recognize, analyze, hypothesis, generate solutions, take actions, and evaluate. And again, we can enrich this with all kinds of stuff with this scenario. So what do they see? So let's go to the next slide. So this is what they see when they get on scene. The patient is sitting awake in a dental suite and does not want to be bothered. They're about 60 kilograms. The office staff states the patient reported feeling weak on arrival for the appointment and then became confused. So that's kind of what they find. Here's the history. The patient has a history of seizures, diabetes, and hyperlipidemia. The patient was told to fast after midnight for a dental procedure. Medications include insulin that's being administered by an automated external pump, carbamazepine, hydrocodone, acetaminophen for dental pain, and atorvastatin, and the patient has no allergies. So there's a little bit of information about the patient's history. And then we tell them about what they actually see with this patient. So the patient's skin is diaphoretic. There's no signs of trauma, and the patient obeys motor commands. The eyes are open, and the pupils are 5 and reactive to light. The vital signs are 156/90, pulse is 124, respiration is 24. SpO2 is 95, the temp is 98. Again, it's Fahrenheit and Celsius. And in this case here, the blood glucose is 47. So I think with that information, we all know that we're dealing with a hypoglycemic emergency. And so we're going to ask them questions about that. After those 3 to 6 questions are answered, we move them to the post-scene phase, and then we go back through that circle again: recognize, analyze, hypothesis, generate solutions, take actions, and evaluate. And you see that here in the bottom, those up to 6 questions here. The enrichment section is the same. And then the information that's given in the scenario is a little bit of information about the post-scene setting and any changes to the chief complaint or the history of the present illness. There's no reason to repeat the past medical history here because we already have it. Then we get some additional assessment and vital sign findings. And then, of course, if the graphic is important, that would be included. And so post-scene, this would look like, despite successful dextrose administration, the patient remains weak and dizzy and vomits. The patient is severely confused and has pale, cool, diaphoretic skin. The patient is shivering, is not following commands, and has removed the IV line. Eyes are open and pupils are 5 and reactive. The vital signs now are 160/92, pulse is 130, respirations are 12, SpO2 is 95, temperature is 98, and now the sugar has come up from 47 to 52. But the patient's really not responding well to the dextrose that we administered on scene. And so we could ask them a series of questions related to that. And so again, the reason I put this slide back in is because when you run your students through these debriefings or these scenarios, man, I would unpack this. I would scaffold this with those students. I would ask them over and over, run through the circle. What did you recognize? What was important? What was not important in that? What do you think you were dealing with? What were some of your options to manage that patient? Why did you pick the action that you picked? And how did you know things were getting better or worse for your patient or the scene there? And so again, run through those steps in a very structured process, and those students will learn to think like this. I'd almost argue that they're already thinking this way. They just don't know that that's how they're thinking. But if you scaffold that and run them through these 6 steps on scene, post scene, and en route, they're going to learn to think that way. And when they get to the National Registry examinations, it's going to be really easy for them because they're used to thinking in that particular format. And so from here, I'm going to transition and actually show you a scenario. But I want you to see that this is on our website. If you see the arrow here, you see the quick links. It says new, experience an interactive performance scenario. The image on the left is that of our AEMT page. And the one on the right is the same thing, new, experience an interactive performance scenario. And this is found on our paramedic website. And so let me stop the share here. And I'm going to go to the website here, and we're actually going to walk through this scenario. Okay, Rio, am I sharing our webpage?
Yep, it looks good to me.
Excellent. Okay. So this is the National Registry landing page. And you'll note that there is EMR, EMT, AMT, and paramedic. If you go to the link that says certification, it will take you to this page, and you'll note there's full education program, learn more. We're going to click on that link. And here's that image I just showed you. Here's the quick links. It says new, experience an interactive performance scenario. I'm going to click on that link. It now takes me to a website where a candidate, where a program director, where a medical director or faculty can actually experience these scenarios. And so, and I'm trying to save a little bit of time here for questions, but this will tell them what to expect. And you'll notice down here on the right, it says next. And this is actually what it will look like for a candidate. This is exactly what they will see at Pearson VUE. So up top, en route, scene, post scene. Here's the information that I just read on those previous slides about our hypoglycemic diabetic patient. The tab for en route is lit up right now. They cannot go to scene or post scene because they have to answer the questions en route first to move forward here. So here's our first question. This is a multiple response item. It says, identify the dispatch information cues that an AMT should prioritize for response and scene readiness. Select the 2 answer options that are correct. And so again, our patient was agitated, so that's pretty doggone relevant. And I believe it was rainy outside. And so they would answer those 2 items, and then they would hit this next button. And so we'll move on. Yeah, look at that. Notice that it says en route here. The en route tab is still lit. It says which of the following leadership roles should be considered en route for this event. And so this is a leadership item is really what it is. And so we'd want to assign roles and responsibilities. I would answer that. This is a multiple choice. Move on. It says what factor for this scene may allow for more precise communications to occur than would occur in many other scenes here. And so the fact that we're on scene with a bunch of healthcare professionals, chances are they have access to this patient's medical history, medications, and all of that. They probably can also help us determine what's wrong with that patient. So let's find the right answer here. There it is. Healthcare providers are on the scene with the patient. And now we've moved to the scene phase. And so again, here's the information I just read to you a moment ago. And here's our first question related to the scene. So it says, which of the following findings are most significant for determining the nature of illness? It's like 2 answer options that are correct. Well, this patient was taking a lot of diabetic meds, and they were unconscious. So that's pretty doggone irrelevant. And when you go back and do this on your own here, you're going to see that the other things weren't quite as relevant. But answer that way. Based on the patient observations, which of the following conditions could explain the patient's current state? Probably had too much insulin and they were fasting, and that's what caused their blood sugar to drop. So I would answer those 2 questions. And then here's our first TEI. So it says, based on the patient findings, what is the most probable medical emergency and what is the correct treatment for that emergency? And so what we want to do is drag over what do we think is the most probable emergency. With a blood sugar of 47 or 52, it's probably hypoglycemia. And the treatment for that would be administering dextrose. No reason for Narcan and no reason for a supraglottic airway. I would answer that question that way. Next question, again, we're still seeing which of the following initial signs and symptoms is consistent with early onset hypoglycemia? The answer here is going to be that of altered mental status. But before I move on from this scene, I want you to show you that I can go backwards and look at the en route information. I can go and look at scene information. Again, I still can't do the post-scene information because I haven't answered all the scene questions yet. But early onset hypoglycemia is probably altered mental status. Oh, still one more. What treatment should the AEMT perform next? In this case here, we want to give dextrose. Or probably, it's 2. Select 2 answer options. So we want to give dextrose, and we've got to start an IV to do that. So those would be my 2 answers. And now we've gone to post-scene. So I can look at this information post-scene. I can look at the information on scene. I can look at the information en route. But let's answer these questions post-scene. Because of the observed patient changes, which of the following actions would be beneficial? Select the 2 answer options that are correct. So again, this sugar remains low. This patient is actually more depressed with their hypoglycemia. They are pulling out their IVs. And so what would we do from here? I think they're vomiting too, if I remember correctly. Let's go look at that. Yep, they vomit. So we want to consider the suctioning here. And then the next thing we probably do is stop the insulin pump. No reason for oxygen because the sats are good. No reason to believe this is a narcotic overdose. And the blood pressure actually is A-OK. So that would be my answers. Post-scene, which of the following therapies should the AEMT consider at this time? Select 2 answers that are correct. So again, I think I would administer more dextrose and I would regain IV access. No reason to ventilate, no reason for a fluid bolus, and patient isn't conscious enough to have oral glucose. For this patient's related condition, this is the vomiting, which of the following medications could help the AEMT, what could they anticipate using? And so we might want to give them a little bit of Zofran. And so we'd answer it that way. Here's another TEI. It says, what conditions are likely to explain the patient's continued signs and symptoms despite the appropriate therapy? Move the 3 answer options into the answer area from most to least. So, so this is probably hypoglycemia. We're going to move that into spot number 1. The blood pressure is a little elevated. I don't think that's the cause of the emergency, but that is a little abnormal. And I don't think the patient's hypothermic at all. Yeah, they're 98 and 37 degrees Celsius there. So I'd answer it that way. I would then move on. And then this one asked me, this is an options box, what changes in the patient signs and symptoms would indicate treatment is improving the patient's conditions, and what changes would indicate despite therapy, the patient's condition is worsening. So if the heart rate increases, yeah, that's pretty bad because they're already at 130. So I would say that's worsening. If they follow commands, that's a good thing. If the skin becomes dry, that's probably a good thing. If we see seizure activity, that would be a bad thing. So that's how I would answer this item. I would move on to the next one. And I've completed the demonstration. And so let me stop this share. I'll do a new share. And we have 8 minutes left for questions. But I want you to see that you can experience that scenario. I know I ran through it very quickly, but you can go there from our webpage and experience that yourself at the pace that you want. And so there is no timer on it. You can show that to your students. You can show that to your faculty. You can show that to your program director or even your medical director. But this is out on our website. We want you to go there. We want you to experience this so that you know what to expect when you get to Pearson VUE. And with that said, I'm going to be quiet, and we've got 8 minutes for questions and answers.
Yeah, thank you, Paul. So we have 2 questions right now. The first is from Michael Touchstone. He asked this back in the first section, the what is competency section. He says, where does effective domain competency fit into this model? An individual can be cognitively a competent clinician, but they're rude or rough or disrespectful.
Yeah, typically that's measured at the program level. And so the educators at that program have a requirement from COA to actually evaluate the effective domain throughout the course, a paramedic course. So that's one place that it gets measured. But we could also ask questions in there about, give them a scenario and ask them what would they do. So maybe perhaps the patient has urinated on themselves. And we could put that in the scenario and ask them how would they manage that. And that would actually measure a little bit of the affective domain, just in the question itself. So, are you just going to leave them in the soiled clothing that they have, or are you going to remove that clothing, or is there some other option? But that would get to that affective domain. But I think we rely on the education programs, to measure that. And I know that is a COA requirement as well, but we can pick those up with items.
Okay, the next question is from Adam Rothenberg. When does this style of examination go live in the NAEMT certification exams?
Great question. It is already live. The AEMTs are seeing these items already, as well as the paramedics. And so again, these items are at a pilot phase, and so they don't count for or against the candidate, but they are being exposed to them now. And what we're doing is gathering the metrics to determine how they perform and the difficulty level of these items.
Okay, the next question comes from Dan Limmer. He asks, what percentage of the exam would you expect to be questions like this?
Currently, that is undetermined, but I can tell you the AEMTs currently are seeing one scenario with about 18 items. And the paramedics currently are seeing 2 scenarios with about 9 to 10 items. Again, our AEMT examination is linear, and there's 135 items on that. And the paramedic is computer adaptive. So the test length depends on, and you see that actually on this slide here. So the cognitive exam, 135 questions for AEMT. And if you move over to the cognitive exam on the paramedic, it is currently 80 to 150 items, depending on the candidate. Our examinations will extend when we start making these operational, but all the details on that will be communicated in the very near future.
Dan Limmer also asks, will this be only for AEMT and paramedic at this point, or will there be EMT now or at some point?
Yeah, so good question. The scenarios, the clinical judgment piece is at the AEMT and the paramedic level. The TEIs are being used, in conjunction with the clinical judgment model for the AEMT and paramedic.
Adam Rothenberg asks, is there an estimated timeline of when these will be live counted questions?
Everything is July 1st of 2024 is the target.
Someone else asks if this webinar will be available for us to reference in the future, and Rio answered in the chat that it will be available on NAEMSE's YouTube channel tomorrow. And other than that, that is the end of our questions, Paul.
And Emily, I would add, if you want to experience that scenario, you can look at the structure of the scenario and you can look at the different item types. And you can also get that feel of that sequential flow of these scenarios from in route, on scene, post scene. And as you educate your students and test your students, I think if you can mimic this, they'll be that much better prepared when they reach the testing centers. And again, I'm really, my big goal today is point you to this resource, this new experience and interactive performance scenario. Again, this is available to everybody that's listening today. And all you have to do is go to our website and follow those links down into this, and then just follow that process. You can do that as many times as you want. You can do it once, or you can do it 500 times.
And Paul, as of right now, we have no further questions.
Well, thank you for the opportunity to visit with you today. If I can ever be of any type of help, please reach out. Please go to our website. Please experience this scenario, and teach everybody you can. Share this information with them so that they can also experience this scenario type testing.
All right. Thank you again to the National Registry for partnering with us today. Paul and Emily, it is always a pleasure to work with you both. Everybody, I will make sure that all of the resources that were in the chat today will go out in tomorrow's follow-up email, as well as the link to obtain your CEU and the link to watch this recording on our YouTube channel. So I believe that brings us to an end. So thank you all for joining, and we will see you next time. Everybody have a great day.